Okay, so today we're going to talk about ultrasound in the intensive care unit, right ventricular function. We're going to talk about pulmonary embolus and other pathology affecting the right ventricle. I have no financial disclosures. So, as you know, all of our ultrasound lectures have been arranged kind of as goal directed echo. So, when I'm coming to the bedside and my patient's hypotensive, what are the five assessments or goal directed in my that I'm looking at in my goal directed echo? So, left ventricular size and function, right ventricular size and function, pericardial fluid effusion, intravascular volume status, and gross valvular abnormalities. Today, we're going to talk about right ventricular size and function and pericardial effusion. So, today we're going to talk about the anatomy of the right ventricle. We'll talk about how we evaluate the right ventricle. And here we will look at three things: size, interventricular septum, and function. We'll talk about PE, pulmonary embolism. We'll talk about RV failure. How do you tell if it's acute or chronic? Talking about RV hypertrophy and the 60-60 sign. And then we'll end with talking about cardiac tamponade. So, remember that right ventricular anatomy is a little bit different than the left. If you make a fist with one hand and take your other hand and wrap it around, that other hand is going to be that right ventricle. So it wraps around the left ventricle. And when it wraps around, we kind of have three sections to it. So we have this inflow track over here, we have the apex, and then we have the outflow track. So this is important to note when we do that parasternal long axis view, that ultrasound beam is going through the right ventricular outflow track. So we call it the RV, but it's really just this tiny blue section here, the outflow track. Also, the right ventricle is thinner than the left ventricle, and it pumps to a low pressure system. So, as we know, it's only pumping to the pulmonary, the lungs, and therefore it doesn't have to create those great pressures that the left ventricle does. The other thing to note here is the moderator band. So, this is a band that goes from the right ventricular free wall to the septum, and it carries the right bundle. And we want to make sure that we know it exists because it can help us distinguish the right ventricle from the left ventricle, especially if we didn't complete the ultrasound ourselves and somebody brought us it. And we also don't want to confuse it for anything else. So here's a video from 5 Minute Sono, one of my favorite websites. So if you haven't already checked it out, please do. Here's an apical four-chamber view: left ventricle, left atrium, right atrium. We see here the positive arrow sign is pointing to the moderator band. Again, it goes from the septum to the free wall right across here. So don't confuse it with a thrombus. Sometimes people have come to me and said, "Oh my gosh, there's a huge thrombus in the right ventricle." Nope, that's the moderator band. But it can help us know that this is in fact the right ventricle, especially when it's large like this and we're like, "Ooh, are you sure that probe isn't swapped?" The other thing that can help us distinguish the right ventricle from the left ventricle is this location of the tricuspid valve. So if you notice this tricuspid valve, the leaflet, the septal leaflet, is closer to the apex than the septal insertion of the mitral valve. So that septal leaflet of the tricuspid valve is more apical than the anterior leaflet of the mitral valve. So again, here's the anterior leaflet of the mitral valve. Here's that septal leaflet of the tricuspid valve, and note that that one's closer to the apex. So if somebody brings you an ultrasound that you didn't do and you're wondering if it's swapped, this is one way you can tell. All right, so let's start with our first case. 57-year-old female with a trimalleolar fracture 1 week ago while biking in South America. They're in the operating room at the conclusion of the ORIF. There's no issues throughout the case. But upon waking from anesthesia, she's desaturating to the 70s. They call for help. Other providers come in the room. A bedside ultrasound is completed. The patient quickly becomes hypotensive, requiring levo-fed. And this wasn't the exact ultrasound, but this is essentially what was seen. This is an apical four-chamber view: LV, RV, LA, RA. We can see here that the right ventricle is severely dilated. We see that the right ventricular free wall is not moving in. And so this is an example of right ventricular failure. This patient is hypotensive due to right ventricular failure. So let's talk about how we evaluate this right ventricle. So we can talk about, we said size, interventricular septum, and systolic function. And everybody asks me, what view do you like to look in? And I say, these are the views that I prefer and why. So size, we look at the apical four-chamber view. The right ventricle should be 2/3 the size of the left ventricle. We can look in the parasternal long axis view, but as we talked about, that right ventricle here that's labeled is really just that right ventricular outflow tract. So it doesn't always tell us a ton about the size, but the RVOT should be about the size as the ascending aorta and about the size as the left atrium. When we talk about the septum should be round here, this is best done in the short parasternal short axis view. And then systolic function, we can evaluate the free wall and we can look at TAPSE. And this is best done in the apical four chamber view, or I also like to do this in the subcostal four chamber view, because as you note in this subcostal four chamber view, the liver is right here and it's a nice acoustic window to be able to see that right ventricle. And you can clearly see that right ventricular free wall and see if it's moving. It's not the greatest view for size because we can often underestimate right ventricular size, but we can evaluate qualitatively TAPSE, as we'll talk about here. Okay, so we said size. This is really best done in the apical four chamber view. So if you're going to evaluate the right ventricular size and compare it to the left ventricle, you have to have a good apical four chamber view. When we talk about size categories, there's three categories: normal, moderately dilated, or severely dilated. So normal, the RV should be less than 2/3 the size of the LV, as we see here. Moderately dilated, it's more than 2/3 the size of the LV, and severely dilated if the right ventricle is actually bigger than the left ventricle. I often say if they're the same size, that's bad. If it's bigger, that's really bad. Just make sure your probe isn't swapped. Another note about size is that the right ventricle should be triangular in shape. And so here we see it's a nice triangle. And thirdly, that apex is dominated by the left ventricle right here. And so this right ventricle should not really necessarily dominate and take over the apex. This is of note when we go to do that apical four chamber view. So this is a picture where, again, I think of my ultrasound beam kind of like a flashlight. And so if I'm at my apical four chamber view, and this is a view of my short axis, but kind of showing where does that beam go through in position 1, 2, and 3, if I'm at my apical four chamber view, you can see that there's a significant difference in the size of the right ventricle compared to the left, just based on this tiny little angle. And so what that means is when I'm doing that apical four chamber view, I always do a teeny tiny rotation back and forth to make sure that I'm at star 1 instead of 2 or 3, that I'm not underestimating the size of my right ventricle. Because if you think about it, if you're in that apical four chamber view, as you rotate to get rid of that right ventricle to end up in the apical two chamber view that we talk about in previous lectures, you rotate until that right ventricle is gone. So just remember, it is possible to be slightly rotated such that your right ventricle should look smaller. So in summary, 1 star is the recommended apical four chamber view of the right ventricle. Notice this difference in the right ventricle despite similar size of the left ventricle, and adjust. You can adjust to acquire a right ventricular focused view. So an RV focused view is actually one that is slightly more lateral than our typical apical four chamber view. And it will oftentimes shift that septum slightly such that your beams go through the left ventricle to get to the right ventricle, and you will more clearly see that right ventricular free wall. Also, the ASE, the American Society of Echo, states that that lateral right ventricular focused four chamber view is the best place to measure the right ventricle. We want to avoid underestimation. So again, we want to rotate until we get this maximal plane, this star 1. And we want to avoid overestimation. So if you have an apical 5 chamber view, or if you're really, really medial, or if you're extremely foreshortened, meaning that you're not down at the apex, but you're higher up on the chest, you might overestimate the size of the right ventricle. Okay, so here we have 3 views. And remember, we said in acute or chronic right ventricular failure, that chamber will dilate, right? It will not be a triangle. It would be more like an oval or a pear. And it might start to take over the apex. So go ahead and take a second to look at each of these pictures, left to right, and think to yourself what size you would rate this, or how you would talk about the right ventricular evaluation via size. So the left one is moderately dilated. If you look here, the right ventricle is about the same size as the left ventricle. And then as we move on, it's going to be severely dilated. So you can see that that right ventricle, which is clearly labeled, is actually bigger than the left ventricle. It's no longer really the small triangular shape that we would expect it to be. And it's starting to take over that apex, as that positive arrow sign shows us up here. And then in that third picture, that's the normal one we've seen where, again, the right ventricle is less than 2/3 the size of the left ventricle. So if we want to measure size, this is that right ventricular focused view that we talked about. So instead of that septum being up and down and we see the LV and the RV just perfectly, we've kind of focused in on that right ventricle as being the center of our view. So our septum is just a tiny bit angled this way, and that is because most likely we've come slightly more lateral on the chest. So if we're going to measure right ventricular size, we want to do it at end diastole. So I think give the right ventricle the chance to be the biggest it's going to be. And if they do a formal echo, these are the three measurements they do. RVD1 here at the base, RVD2 midway, and then RVD3 is lengthwise. Here are the dimensions that are listed. I always like to make things easy to remember. So I think 41 is the number I kind of tend to think. If you remember, D1 is abnormal if it's greater than 4, and D3 is abnormal and it's greater than 8. 4 times 2 is 8. So I think, okay, that's kind of an easy way to remember. So if I'm usually measuring these, it's going to be D1 or D3. And even then, D3, it's highly likely in our POCUS views that our apical 4-chamber view might be slightly foreshortened and we might be underestimating that size. So if I'm measuring, I'm usually just doing D1 and just memorizing that greater than 4 is abnormal, 4 centimeters. We talked about at the beginning evaluating that interventricular septum to determine volume and or pressure overload. So here's that apical that parasternal short axis view. You can see here, normally you'd have a circular left ventricle and a crest-centric right ventricle. But as you get right ventricular pressure and volume overload, that is going to push on that septum, and you might see what we call here the D sign, where that left ventricle looks like a D and that right ventricle is pushing on it. A lot of people, when I'm scanning, will say, I don't really see the right ventricle that often. And I say, that's usually good, because if it's abnormal, you will start to see it. So again, the normal LV is circular with a crescent-shaped RV. When the pressure rises, the septum flattens and is pushed towards the LV, and that normally circular LV becomes D-shaped. The board's answer, and the answer that's helpful to know is that if you have volume overload, it will be flat during diastole. If you have pressure overload, it will be flat during systole and diastole. Of course, it's usually not all of systole, so you might start to see what a lot of people refer to as a septal bounce, where you see that flattening during either part of systole or only during diastole, and that's that increase in that right ventricular pressure. Also, I'd like to note that sometimes in our patients, especially if they're lying flat on their back, we end up coming down further on the chest to get that short axis view. And sometimes we end up coming so low that we're getting really close to that apical view. And in that apical view, that septum is actually flat. So sometimes this flattened septum can be not pathological if you're very low on the chest and you're just angled up and catching the septum at an odd angle. But of course, you should be able to confirm that with other views of the right ventricle. And if you see this huge dilated right ventricle, that can also give you some information. So here's a video we have, again, a parasternal short axis view. This is a circular left ventricle. This is a very large crescent-centric right ventricle. We see that it's large, dilated, and if you focus your eye right here on that septum, you'll see that flattening. That is through diastole and some of systole as well, and you can kind of notice that septal bounce there. So the third way we said we can evaluate the right ventricle is the function, and here we're going to talk about TAPSE, or tricuspid annular plane systolic excursion. So the right ventricle, most of its fibers, or its fibers that help it contract, are longitudinal. And so those contraction of those longitudinal fibers will cause this lateral annulus of the tricuspid valve to move up towards the apex. And so that's why TAPSE, or tricuspid annular plane systolic excursion, is a good measure of determining right ventricular function. In our global left ventricular function lecture, we did talk a little bit about MAPSE, using it for the left ventricle or the mitral valve as well. But it's very commonly done here for the right ventricle. So how we would do this officially, or to get the quantitative number, you can do it qualitatively. Just look at this lateral annulus and see if you feel it's moving towards the apex. Quantitatively, we would put M mode or motion mode, which this line will appear, and that will graph motion on the y-axis over time on the x-axis. And so this black or anechoic area right here correlates to this black or anechoic area. This hyperechoic or bright white area, that's the lateral annulus. And this is that movement of the lateral annulus over time. It's moving up because it's moving towards the apex here. So you would get this tracing, and then you would measure essentially this peak to trough, this height right here, and that's going to give you your TAPSE or tricuspid annular plane systolic excursion. I put things in red that I think are worth memorizing. I think it's helpful to know that a normal TAPSE is greater than 17 millimeters or 1.7 meters. So again, you're going to put the M mode cursor through the tricuspid lateral annulus and the apex. So the top does have to go through here, the apex, and the apical four-chamber, and it's going to measure the longitudinal displacement of the annulus at systole. Normal is greater than 17 millimeters. So let's go on to talk about pulmonary embolism. This pathology has a high mortality. POCUS can help validate our clinical suspicion. So if you have a DVT and a suspected PE, that's very specific for the diagnosis of PE. POCUS helps tell us about the severity of the PE. So if our RV to LV diameter ratio is greater than 0.9, remembering that normal is going to be 0.6, then we can classify it as a submassive PE, and that might change our treatment. And then of note is McConnell's sign. So McConnell's sign is when you actually have akinesis of the mid-free wall, meaning that right ventricular free wall is not moving in, but you do have normal motion of the apex. And oftentimes, this is because that left ventricle is hyperdynamic and it's kind of tugging on the right ventricle. So this is an example where you can have a normal TAPSE, but you still have significant right ventricular failure. And that's because that lateral annulus of the tricuspid valve is moving because that right ventricle is being tugged on by the hyperdynamic left ventricle. McConnell's sign is specific but not sensitive. So here's an example of McConnell's sign. So we have LV, RV, LA, RA. We clearly can see that our right ventricle is not functioning. We have RV failure. We see that it's dilated. It's actually bigger, I think, than the LV. We can see that this free wall is not moving in. But if I were to actually calculate a TAPSE, so if I were to put M mode through the apex and the lateral annulus, I can do this qualitatively by just putting my cursor here. It would actually have probably a decent TAPSE because it's being pulled by that hyperdynamic left ventricle. So don't let a normal TAPSE fool you into thinking that the RV is normal. You still have to evaluate the RV size. And most importantly, or I think most helpful, is to look at this right ventricular free wall. So is the right ventricular failure acute or chronic? You can look at an old echo. I think that's probably the most helpful. You can look at right ventricular hypertrophy. So is it thickened? And then you can also look at the 60-60 sign. So this is 94% specific for a PE. This is when the right ventricular systolic pressure is less than 60 and the pulmonary acceleration time is less than 60. The thought being that a very high RVSP can only be generated in the setting of chronic pulmonary hypertension. When you guys have patients in the CT ICU, right, they don't have PA pressures of 73, that happened overnight, right? These patients have to have chronic time for that right ventricle to hypertrophy and be able to handle and sustain those high pressures. Pulmonary acceleration time, this is the time it takes for the pulmonary velocity to peak. And the thought is that if the time it takes for it to peak is short, this indicates a high pressure or resistance to flow. And so if that pulmonary vasculature is not used to these high pressures, it's not going to accept them and it's going to peak very quickly. But if you have a longer pulmonary acceleration time, that's going to suggest that the pulmonary vasculature are rather compliant and they're accepting this greater right ventricular output. So this is a subcostal four-chamber view. You see the liver here at the top, right ventricle, right atrium, left atrium. It's kind of like an apical four-chamber turned on its side. We see that the atria are enlarged specifically, especially that right ventricle. And then here, we see that we have a significant amount of right ventricular hypertrophy. So if I see that this patient has a dilated right ventricle, I'm not necessarily jumping right to RV failure or PE because this might be some chronicity to it. So a normal RV wall thickness is less than 5 millimeters. This is a subcostal four-chamber view. Again, here's the liver, RV, LV, RA, LA. You would measure, this is one of the best places to measure because you can see the wall very clearly right next to the liver here. You're going to measure during end diastole. So give the right ventricular wall the chance to be the thinnest it's going to be. More than 1 centimeter strongly suggests chronic. And then you can have acute on chronic RV failure. So again, just because the patient has chronic RV failure doesn't mean they don't still have an acute PE. And then this right ventricular wall can hypertrophy within 48 hours of an acute insult. So how are we going to calculate the 60-60 sign? If you remember, we talked a little bit about RVSP, or remember, RVSP is the same as PA pressure if there's no significant pulmonary outflow tract obstruction. And you can also go back and listen to the lecture on the IVC that will talk about this if you need more of a review. But to calculate the 60-60 sign, we are going to get the RVSP. So first, this is an apical 4-chamber view. You can do continuous wave Doppler across the tricuspid valve. You're looking at tricuspid regurgitation, so the blood that's going back into the right atrium during systole. That blood is going away from the transducer, so that's going to be a negative Doppler shift. So here's your tricuspid regurgitation. Here's your max velocity. Bernoulli's modified equation is going to take that max velocity and give you a change in pressure. Then you would add the change in pressure across these 2 chambers to the right atrial pressure, and that will give you your RVSP. So to get the right atrial pressure, again, we did this in the hypovolemia lecture. If you want to go back and listen to it, here's our IVC. We would say, is it greater than or less than 2.1 centimeters? Does it collapse greater than or less than 50%? And based on that, it would be given a right atrial pressure of 3, 8, or 15. And remember, this can be helpful because a very high RVSP, or really it's the same again as PA pressure, can only be generated in the setting of chronic pulmonary hypertension. So it might make me think a second before jumping straight to an acute RV failure. Pulmonary acceleration time is, again, the time it takes for the pulmonic velocity to peak. And if it's short, it indicates a high pressure or resistance to flow. This is a short access view at the level of the aortic valve, also called an RV inflow-outflow view. Here's your aortic valve. Here's your right ventricle, left atrium, inner atrial septum, right atrium, tricuspid valve, again, right ventricle, pulmonic valve, PA, right and left PAs. You're going to put a pulse wave Doppler right here. And this would actually be a scooped out waveform if we were being totally exact. But again, this is doing velocity over time. So velocity on our y-axis, time on our x-axis. And the blood is going to be going out the PA, right? So it's going away from my transducer. Therefore, it's also a negative Doppler shift. And here's the speed. So again, I said time is on my x-axis. Here is the time from the start of flow to the peak velocity. So this time right here is going to be that pulmonary acceleration time. And again, if it's short, less than 60, we are going to more likely assume that this is acute. A lot of people say, well, why do you care? How do you use this? This is for LVOT-VTI. So in the global function lecture, I talk a lot about LVOT-VTI. So if you want to review that, you can go back to that lecture. But the velocity time integral in the LVOT correlates with cardiac output. And so this is a lecture, or this is a study, sorry, that talks about how we can use LVOT-VTI to help risk stratify our patients with PE. So in this paper, a normal LVOT-VTI is 18 to 22. This paper defined a low one as less than 15, so even lower than what would be considered low for normal, or lower than normal. And this study showed that a low LVOT-VTI was the strongest predictor of shock or need for reperfusion. And a low LVOT-VTI was associated with death or cardiac arrest, but RV dysfunction was not. So yes, I might care to look at my RV dysfunction or RV strain if I know they have a PE, but really the next thing I'm going to be doing if I have a presumed PE is going on to look at LVOT-VTI to kind of risk stratify my patient. And if they have a low LVOT-VTI, which again would correlate with a low cardiac output, then I'm going to be more concerned that they could decompensate. And so VTI may help risk stratify patients with intermediate high risk pulmonary embolism. So back to our case, the patient was started on Levophed, epinephrine, vasopressin. She was diagnosed as a presumed massive PE, too unstable to get confirmatory imaging, of course. She was given TPA, and her hemodynamics improved over the following 2 to 6 hours. All right, next case. This is a patient who had a cardiac arrest on the floor. She is a 32-year-old female, history of lupus. She was about to be discharged. She says, "Oh, I feel short of breath." She collapses, no pulse. CPR is done. They get RASC. She arrives to the ICU. She's intubated. EKG was read as a STEMI, what was actually non-specific ST changes. And so the first step, of course, is to grab my trusty ultrasound, my echo, and do an echo. And this was not her exact ultrasound, but this is essentially what I saw. So this is a subcostal 4-chamber view, although I have trouble calling it a 4 because you can barely see this little chamber right here, but this is tamponade. So here's your liver, here's your large effusion, LV, LA, RA, and here's your RV that is trying to fill, but is not. So pericardial effusion and tamponade. Pericardial effusion is just fluid in the pericardial space, more than 50 cc's. It can be due to malignancy, uremia, trauma, infection, rheumatologic diseases. This is best seen and quantified in the subcostal 4-chamber view because as you see, that fluid is going to be most dependent and you're going to see it collect there between the liver and the right ventricle. I also think that's the best view to be able to evaluate if there is tamponade because again, you could see that fluid right up next to that right ventricular free wall and you can see if there's indentation. Remember that the effusion may not be circumferential in post-cardiac surgery patients. You want to measure at the largest point in diastole. We'll make your numbers easy. So we'll pick 1, small is 1 centimeter or less, moderate to large, more than 1 centimeters. And then of course, what we really care about in POCUS is tamponade, right? So that's when the pressure in the pericardium exceeds the pressure in the right ventricle and you start to have impaired cardiac output, usually of course, due to the lack of RV filling and pushing of blood to the LV from the RV. On ultrasound, you'll start to see RV diastolic inversion. So essentially that right ventricle can't fully expand in diastole. It's being pushed on by the pressure in the pericardium. So that free wall is essentially indented by fluid. And then if you go on to do an IVC, you'll also see a plethoric IVC that does not collapse. So here's 2 pictures. And the question is, which one is truly tamponade? Now, a lot of people will say one is tamponade and tamponade's cousin. But if you look very closely in these both subcostal 4-chamber views, RV, LV, RA, LA, this one, that right ventricle is still able to fill somewhat. And so while there may be some minor indenting, this one is one that you hopefully have time to intervene, have cardiology see them, versus this one, you can clearly see that there is tamponade, that RV is not able to fill at all. However, of course, based on the Rush protocol, this large of an effusion in any hypotensive patient requires further evaluation. So back to our case, the patient coded again, and so a pericardiocentesis needed to be completed at bedside. So here is a quick reminder of where you can insert the needle. Subcostal, peristernal, or from the apical. I have always been taught and done from the subcostal view right here. If you have another provider, it's best if they can hold the ultrasound across the chest right here, kind of peristernal for you. And you're going to want to insert the needle into the epicardial or pericardial space until you receive blood. Generally, if I'm the one doing it, because the patient has had a cardiac arrest, I'm not even threading a wire. I'm just getting into that space and then having people hand me syringes and continuing to pull off fluid until it's enough to relieve the pressure and get RASC. Remember, pericardial fluid does not clot, so that can help you feel more confident. And if you don't have a pericardiocentesis kit available, you can also just take the needle and the catheter if you do decide you want to thread something into the pericardial space, and you can just use the needle and the catheter from a triple lumen catheter kit. So if it's an emergent instance. So in this instance, I took the needle from the pericardiocentesis kit because I already had it nearby and at bedside, and it was inserted from the subxiphoid space, and 600 cc's of fluid was removed, which is pictured here, and RASC was obtained. So in summary, we talked about evaluation of the right ventricle. Size, again, the RV should be 2/3 the size of the LV. This is best done in the apical 4-chamber view. Interventricular septum flattening can be used to assess RV function. This is best done in the peristernal short access view. For function, we can look at TAPSE or tricuspid annular plane systolic excursion. Quantitatively, this can be done in the apical four-chamber view, or qualitatively, we can also evaluate that right ventricle function in the subcostal view. For RV failure, it might be wise to take a second to think, is this acute or chronic? To help determine this, you can look at our right ventricular hypertrophy. Normal right ventricle is less than 5 millimeters. And then there's also the 60-60 sign. So you don't develop a PA pressure or an RVSP greater than 60 acutely, and a short pulmonary acceleration time shows that there's a high resistance to that flow and that that's more likely acute. And then we talked about cardiac tamponade. Thank you.